At the American Heart Association meeting in 2014, one of the topics of conversation and great debate is certainly dual antiplatelet therapy. And we know that following PCI for non-STEMI, a P2Y12 antagonist is recommended for 1 year. After some of the data here, that probably is going to continue for a while. What about pre-treatment? Well, as of ESC in 2013, some surprising results from ACCOAST-PCI. And we're talking about the effect of Prasugrel pre-treatment strategy. Now, I'm with Dr. Giles Montalescot, who is an MD, PhD, and chair of the Department of Cardiology at Pitié Hospital, and we're talking Paris at the Institute of Cardiology there in France. Now, you did the original presentation, and I believe it came out of the New England Journal, you said? So let's talk about the original ACCOAST results before we get into what's coming up in JACC. What did you find?
In this study, what we looked at is that NSTEMI presented to the emergency room or the cardiology department being randomized for pretreatment with Prasugrel immediately at presentation versus no pretreatment when you decide for an invasive strategy within 48 hours. And what we found is actually pretreatment, even with one of these new drugs, very potent, rapidly active, did not protect the patients better against ischemic events. And actually the number of ischemic events was exactly the same in both arms.
Did that kind of surprise you?
Yes, because we lived with the idea that pretreatment was good coming from cure performed almost 2 decades ago, and that was a whole different issue. Conservative management, patients didn't go to the cath lab easily, very few PCIs, that was only performed in 20% of patients. So it's a different story, a different era also.
Right. Now, this is in the December 23rd issue of JACC, and what are you looking at?
And actually we had more bleedings, but no efficacy with pretreatment. So we were...
So you had the cost, but you had no value for the cost.
There was only harm.
Yeah.
Only harm. So it's just like with 2B3 inhibitors in the past. You know, we started by giving these drugs early on, and it became a class 3 because there was more bleeding and no benefit. Exactly the same story. And that was a surprise to us, no benefit at all. And of course, in this population, wide population, 30% of patients didn't have PCI. Those going to cabbage surgery, no benefit of pretreatment. Those medically treated, those with normal coronaries after the angiogram, no benefit. So it was very important to look at the PCI subgroup of patients, because if anything, pretreatment has been invented for PCI. We want to have full treatment, effective treatment when we inflate the balloon.
Well, in the editorial comment that accompanies your paper, the authors say it's rather remarkable that the best timing for the initiation of P2Y12 inhibitors in NSTEMI has not really been clearly established up until now.
It's correct. Even with clopidogrel, we do not have a randomized study like ACCOAST to say pretreatment is good or bad. So, you know, it's in the guideline. We have recommendations for pretreatment, but no study, no randomized study for pretreatment. We have CURE, which was not, you know, a study of pretreatment versus no pretreatment. We have CREDO. All the patients were treated after the coronary angiogram, so this is not a study looking at pretreatment. We have no study with ticagrelor, and this is the first study with Prasugrel.
So the editorial commentary, I believe, that in part of the title is loading after CE.
Yes.
Is that kind of the bottom line here?
It's exactly what we should do, especially when you work in a high volume center, when you send a patient to the cath lab rapidly within 24 hours or 48 hours. You can wait. Nothing is going to happen during this waiting period. And you are not going to pretreat and over-treat many patients who do not deserve the treatment.
So in terms of the debate going on here at AHA, in terms of dual antiplatelet therapy, I know in Europe some of the standards are to not necessarily go for a full year, to some, maybe sometimes go a little less. Now, after some of the results here, what are you going to do?
It's a different question. I think this year, in 2014, we have had great news, and we see clearly what we should do with antiplatelet agents. First, avoid pretreatment in non-AC elevation ACS for sure, and stable patients for sure. Look at the coronaries first. When you start treatment, you have to continue for a period of time. Would that be 6 months, 12 months, 24 months, 30 months, for lifelong? Nobody knows, and I think there is no magic number. If you have a high bleeding risk patient, 6 months is fine. We have now 7 studies, randomized studies, all too small, but all together they say less bleeding if you treat for 6 months, no downside for ischemic events. But for secondary prevention, longer treatments, longer than a year, the DAPT tells us that actually you may have a benefit on MI and stent thrombosis with a very long treatment. So select the patients, no excess bleeding risk and probably a high ischemic risk would make the point for a long treatment.
So when you're making the decision, where do you make that cutoff in your own mind as to whether to go longer or not?
You know, we should, the first question to be asked is probably between 3 and 6 months. If you have a patient who requires, for example, oral anticoagulation for AFib, stop your tionoperidine, for example, after starting. If you have a high bleeding risk, a prior history of bleeding, stop your treatment. If you have a patient with, for example, a need for surgery, cancer, why should we wait a year when you can stop at 3 or 6 months? Otherwise, continue up to a year, and at 1 year, ask yourself, would that be good to stop, or shall I continue the treatment? Because these patients are, you know, 4 stents in the lady. The lady was 2.5 millimeters. Is a diabetic patient, still smoking, whatever. And these patients would perform better with a long treatment.
Well, this is a very interesting pair of papers, so please do check out the December 23rd issue of JACC, the paper by Dr. Montalescot, and the accompanying commentary that takes a really interesting look at this particular issue. For Cardio Source World News, I'm Executive Editor Rick McGuire.